work with, as a psychotherapist and as an eating disorder director of a program, I have seen absolute miracles occur. So I want you to think about, before I get into the PowerPoint, I want you to think about the parts of your life that are influencing you at a level you might not even realize. And instead of Maslow's theory, I have the Janet Whitney theory of modern society and how our lives go. And I think that at the bottom of the circle is food. Our relationship to food is so important. It's not like alcohol or drugs or exercise or things that you can give up. Food will determine if you have a zest for life or if you're leaving life. And that's why I call this starving to live. The women who have eating disorders absolutely restrict to a level where they can't function, their brains aren't functioning as their bodies give out. And if any of you have known somebody with an eating disorder, you'll see that they push the food around, or they'll have an excuse for not eating, or they'll say they've already eaten. They have all sorts of things that they're saying to themselves and to others. But if 30 million people have an eating disorder, and I think that's a low number, there are a lot of us around here. And we're going to cover the symptoms of eating disorders, but I want you to first think about your relationship with food. Do you live to eat? Do you eat to live? Or is there somewhere in between? And how much trouble does food cause you? Because if you're doing well with food, you can go on to the other levels. And the next level is money, which is really funny. I'm not a money person. My daughter Hannah knows this, that I sold everything, walked across Spain with a backpack for 500 miles and only had what was on my back. And I know that you can live without things, but money absolutely represents giving and receiving. And so if you come from a feeling of lack, that there's not enough, you'll have this feeling of holding on and restricting. And it's so much like eating disorders where they restrict. Or you have people who are binging, who are overspending, overgiving, and then they have that opposite problem. So this is a circular relationship. The third part that I talk about is your relationship to whatever that energy is that unites all of us, whether that's God, the universe, whatever you want to name it. If you're feeling trusting, you can go out and believe that things are going to work out. But if you're feeling fear, you won't do what you want to be doing. You won't let yourself or allow yourself to be all that you can be. So you look at all three of those, and the fourth one is your relationship with yourself. If you don't have self-acceptance, self-love, it means you're going to have these feelings of unworthiness. And that's going to be reflected in all those other parts. You're probably not going to either do well with money. You might have a whole lot, but you don't share it. Or you may not have any. And you may not do well with food or even your relationship to whatever this force is that puts us together in this journey. So think about your own relationship, and we're going to talk about eating disorder people because they are absolutely going through a process that unless we understand it, there's no way to help them. I think most of you know, but I'll just say it again. The eating disorders have the highest mortality rate of any mental illness out there. And the mortality rate is probably higher than we realize because people die from their hearts giving out or other symptoms, organs giving out, but on their death certificate it doesn't say eating disorder, it says organ failure. So we're looking at a much higher mortality rate than we even know. So as many as 50% of individuals with eating disorders also have depression. But if any of you have gone with low energy because you're not eating, you can have depression because you're not eating. And anxiety goes along with that. Any of us who feel anxious at times, it can be that we're just hungry. Now these women and men are absolutely starving themselves, or if they are eating, they're getting rid of the food. So of course they look anxious and depressed. And I'm not sure, and the depression and the anxiety could have come first, but certainly the eating disorder aggravates it. So I want you to think about the people in Africa or other nations where they don't eat because there's no food. And they are in so much pain because living without food is very, very painful. They can divorce themselves so much from what is actually happening. So they don't know when their hearts are irregular or that they're feeling the cramps from the low potassium or that organs are giving out. Self-harm represents 25%. We have to check our people for everything as far as cutting or doing things that can hurt themselves. And you can have a couple diagnoses for eating disorder. You can absolutely be anorexic and bulimic at the same time, so we're going to talk about that. So because an eating disorder is so complex, we're trying to do a program, and we are doing a program that hits the holistic person. It hits their mind, body, and spirit so that the chances of recovery are so much greater. And a lot of times there's a co-occurring substance abuse. So we have people at Sovereign that have had a meth addiction that find out they were addicted to meth because they wanted to be thin. And then they come into the eating disorder program because it's really an eating disorder that is pushing them underneath all of that. The estimates are that only 1 in 10 women or men will seek treatment for eating disorders, but they don't always even get eating disorder treatment. They go to other treatment centers. So what we want to do is increase the prevalence of eating disorder programs and make sure these people get into actual eating disorder treatment programs. That is what's going to save people's lives. So we do things the Sovereign way, which is, I heard Adrian talk about negative press and stuff, but if you walk into Sovereign, you feel so much positive energy and so much help from all the people that work there. I'm so proud to be a part of it, and just knowing that I can turn to anybody that's a part of the group, and they are all so helpful. So I just want to promote the people that are here from there. So eating disorders are not about food. We think they're about food, but food is just one aspect. It's like a symptom of whether we drink alcohol or over-exercise or whatever we do to cope with our feelings. Underneath the eating disorder is depression, anxiety, self-hatred, these feelings of maybe post-traumatic stress, all sorts of things that are going on. And unless we can get to those feelings that are underneath the eating disorder, even if we get them eating right, they're not going to get better. We need to get to the bottom of those feelings. So we work very hard at Sovereign to get to those feelings. I'm just going to go over the statistics because I think they're alarming. So if over 30 million people suffer from eating disorders, that's a huge part of our population. That's just in the United States. 25% of college-age women engage in binging and purging as their means of weight control. That's a lot of women out there using this as a way to stay thin. 10 to 15% of eating disorder people are male, and the males find it more shaming than even the females because it's been this normally young female disease. So men who are suffering from it are not as identified as easily and actually can be much worse than the women at times. When I read this statistic of 81% of 10-year-olds worry about being fat, I wonder what we're doing in this country by promoting thinness as the goal. Health should be our goal, so that's what we're working on. So 50% of women or men that are anorexic will develop bulimic patterns, so it gets more complicated. They're already starving themselves, and then when they do eat, they'll make sure they get rid of the food. 20% of people with anorexia die prematurely due to the complications, and again, that's such a lower number than what I think is true because they're just not identified. People are having a hard time saying this is an eating disorder. They're just saying their heart failed. And I know we've been in treatment programs where somebody will die in the middle of the night because their heart stops. So what happens is the potassium gets low, the heart gets irregular, the heart gets affected. So the person with an eating disorder gets very confused. They get very confused about, what do I eat or do I not eat? I was given a presentation the other day, and a lady said she gave somebody an orange, and by giving it to one of these patients in the mental health program, she didn't know she was an eating disorder, and the person went and jumped off the balcony or something crazy. She goes, why would somebody do that? And I said, because it's like that movie 127 Hours where the guy has to decide whether to cut off his arm or stay in the rock and die, that true story. That's what an eating disorder person feels like. Do I eat and feel fat, or do I not eat? And so that dilemma of food is just so huge. We also refer to eating disorders as ED or ED so that we can separate the eating disorder from the person. I have a person that we were working with before, and instead of saying throwing up was disgusting, she'd say, I am disgusting. And we want to separate that out so that they feel like it's not them, it's a disease. We're going to find more about what happens in the brain too. So it's a coping mechanism that they feel has worked for them. Maybe they came from a family where everybody was overweight. Maybe they came from a perfectionist family. There are genetic predispositions, but then what also happens is trauma or other things push them into this disorder. When I looked at the funding available, I was really alarmed by this. Alzheimer's affects 5.1 million people, and they get $450 million a year funding. Autism affects 3.6 million, and they get $160 million in funding. Schizophrenia affects 3.4 million, and they get 276 million. And eating disorders, which affect 30 million and has the highest mortality rate, only gets 28 million of funding. So as we wear our purple ribbons and we talk about eating disorders, we need to increase the awareness and the treatment of this disorder. So eating disorders has effects on relationships because it's very secretive. These people want to go off by themselves. They may be hiding food, they may be ordering food, they may be going to like soup and salad places and getting plates full of food. One of our senior clinicians just saw somebody doing that, going back and forth, and then very quickly she went to the bathroom to throw up. So what happens is families get so, like this is their child, and they get so concerned and they want to keep their child alive, and they don't know how to react. All they know is they're coming out of fear. And what we want to do is instill hope. And so our program is going from a positive, non-punishment approach to there are ways to cope with this. Friends and significant others, boyfriends, co-workers, classmates, everyone gets concerned when they start to see someone get weak and pale and lose their hair and the different things that happen. So it's a very traumatic disease. For anorexia, it's an intense fear of gaining weight or of becoming fat, or persistent behavior that interferes with weight gain even though at a significantly low weight. They're typically perfectionist and exhibit black and white thinking patterns and live in extremes, but they're struggling with self-doubt, low self-esteem, and low self-worth. They feel like their bodies is the only aspect of their lives they can control, and so to be able to starve yourself shows immense control. To be able to force yourself to feel so much hunger that you no longer feel the pain of that in your body takes enormous determination. And a lot of times when we're working with our people, I notice their strength, and I notice like they could cure cancer with the kind of energy they're doing with trying to starve themselves. They are the most determined, bright, talented people, and yet they're hurting themselves. You guys probably know most of the signs besides the low weight, distorted body image. We're going to show a slide where the woman looking in the mirror is very thin, but she sees an overweight person. And now they're finding that the brain actually changes so that when she's looking in the mirror and sees that difference, she actually sees that. It's not only psychological. They're finding brain damages that create that distorted self-image. So as we start to be able to treat the brain in that way, it'll certainly help us with treating people. They have intense fear and anxiety about food and gaining weight, and yet the next one, their preoccupation with it, you'll find them playing video games of how to grow food, how to make food, how to cook food, how to serve food. It's very interesting what they do. And then if they do eat, they feel guilty. They deny their low weight. They have high levels of anxiety and depression, low self-esteem. We talked about the self-harm and the withdrawal. They have excuses for, like I already ate a big breakfast, I don't need to eat lunch. They have rigid rules and rituals, intense dramatic mood swings, and the use of laxatives, diet pills, or diuretics. It can go so far as they're using meth and cocaine to control this. And then we have excessive exercise. This is what happens with the body, and we talked about the brain. They'll not think clearly. So if you have somebody who's very severely injured, their eating disorder, and you try to say to them, sweetie, you need help, or whatever it is, they're not going to hear you. They kind of hear like blah, 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 because the eating disorder has affected their way of their brain functioning. You'll see that their hair becomes thin and gets brittle. We just had somebody who came in and said, when I started losing my hair, I knew that I needed help. So it was like the wanting to look good again. Heart, you have low blood pressure, low pulse, irregular pulse. Anemia, you'll see bruises, and so if you're out there in the community and you see a thin person with bruises, it's because they just their body can't withstand the pressure. With bulimia, that's the recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. And in the DSM-5 now they're saying even one episode of bulimia a month is enough to characterize you as a bulimic. They have similar characteristics, but they use purging to gain a sense of control and relieve their feelings of shame and worthlessness following just eating. They're warning signs. So You'll see people eat incredible amounts of food. You'll find, if you have somebody in your family, you'll find food missing. You'll find that they hide food. But one of the big indicators is they'll eat this large meal and then run off to the bathroom or the shower or someplace like that. But you're going to find, again, irregular heartbeat, low pulse, low blood pressure, dehydration, problems in all the body fluids like potassium and sodium. The intestines stop working. These women and men learn how to keep food higher in their stomach so they can throw up later on. They may not throw up right away, but they've learned how to keep it up so they can throw up an hour or two later. So the brain is still foggy. It's hard to make sense. Their cheeks might get really puffy. In their mouth, they'll have their teeth start to decay and disintegrate just from the acid. And then the problems with their throat. If you hear somebody clearing their throat a lot, it's because they've been throwing up and the acid's been hurting their throat. Most of us have some form of disordered eating. I would love to kind of do a survey of what we do, especially California, New York, some of these places where there's a high expectation of people. And so disordered eating is where you may have patterns of eating that don't create health complications or social complications, but they're not exactly normal eating habits. So it could be from restricting meals to sitting in front of the TV and eating a whole pizza, or exercising and running marathons. And I really don't know where to cut the line with disordered eating, because I think most of us have symptoms of that on some level. It's just that it doesn't ruin our relationships, our bodies, our employment. We continue to function. I would like to see food just be a non-issue for people, but somehow it has a lot because it's comfort, it's nurturing to people, or it's their enemy. This is what I was talking about with the body dysmorphia. When the brain actually changes, this is what they see. They actually see an overweight person even though they're that thin. And we talked about it's genetic, it's social, and it's psychological. So if you have the genetic predisposition and then trauma occurs, it's a perfect setup for this. We're going to talk about the myths. There's so many myths about eating disorders. The first one is that it's about vanity. Hopefully I've conveyed to you it's not about vanity. These people have very low self-worth. They don't feel good about themselves. They're hurting inside. They are not vain people. They may look a little narcissistic because they're in their disease, but they're not normally narcissistic. They're just feeling that way because they're surviving. The other one is that you have to be underweight to have the disorder. Many people are average or overweight that are doing the binge eating and purging, so you can't just say, oh, she's okay weight. We actually had somebody at our program that a driver said, oh, you look okay, which devastated her because it makes her feel like she's overweight. They could just stop if they wanted to. If it was that easy, would we be doing this treatment? It's so ingrained in their whole behavior and their minds and souls, so they can't just stop. They can't just start eating. It isn't that easy. The interesting part is we have to get below to what's happened, what we can change about their beliefs, and what we focus on is their strengths. How can they recover? And they can recover when you build up their strengths. So eating disorders don't discriminate. It can be any age, any sex, any ethnicity. Our goal is to turn self-hatred into self-love, self-harm into self-care, and self-destruction into self-acceptance. Our mission is to help individuals with eating disorders develop and maintain a healthy relationship with their minds and bodies. We will work to reverse disordered thoughts and behaviors regarding food and body image. And we're going to do this by a holistic approach using our dietitian and all that we do. So we do a lot of mindfulness and things like that to bring them into the present. Here's the list of all the things we do. We include yoga, equine therapy, CBT, body image, nutrition. But I'll tell you, it's these people know how to heal each other. Eating disorder people do not try to hurt other people. We never have to worry that they're going to attack one another or do anything negative to one another. They turn their energy to hurting themselves. So we want them to start as a group bonding with one another, and through seeing they're not alone, that they can then recover.
I think one of the main goals of nutrition therapy, like she mentioned, is basically replacing the disordered and unhealthy eating patterns into more healthy and organized eating behaviors. This sounds easier said than done, just because they all come with a history of restriction or binge purge. So you're dealing with a variety of individualized cases and where basically the history is. Our point is to basically bring them to a more medically fed and nourished state, so that all the therapy, whether it's psychotherapy or nutrition therapy, that we're hoping that they will pick up from there, if they're in a starved phase, they're not really going to be grasping any of the concepts. They're just physically present. So we're hoping that the more they're eating, the better they're able to implement some of the therapy and be more involved. Our interventions and approaches towards reaching nutrition goals. Number one, of course, is nutrition counseling, which kind of incorporates a mix of CBT. They'll be more interactive and relational and educational techniques, and I'll talk about the different education topics that we will use. One of the things that makes them get into their eating disorder is that they feel they have control over their food. So really making the clients be involved in their choices. So it sounds, a little bit double-edged sword. Well, they're not making healthy choices. They're restricting at, before they came in. So how do you give them that control? So it starts off with a little bit of a structure initially, which is kind of like our meal planning and telling them, where I would figure out how much calories they need and how we're going to spread out the meals, and just have regular meal spacing. That itself will regulate their own internal metabolism. But giving them the options, for example, okay, if you were to, learning about carbohydrates, fats, and proteins, well, you learn to pick your choices out of a food group. So that gives them a little bit of control. I'll share something that happened this morning in session. One of the clients doing very well with her meal plan. And there's a lot of emotional stuff going on. And after we kind of talked, what came out of it was she felt restricted to eat a bread. Now, interestingly, she was eating sandwiches at lunch, but she thought a bread, which to her is a comfort food at any time of the day, she thought the meal plan wasn't allowing it, so she actually wanted to do AMA. One of the things that really frustrated her. So after talking, and Jade was there, and actually she kind of intervened. So we talked about the bread. Well, if you were allowed a bread, how would you feel? Well, I would feel better. Okay, well then let's eat the bread. So there was just that much where she thought it wasn't just 3 meals, 3 snacks, but I have a little bit of control over when I want the piece of bread. And it's typically in the afternoons, things like that. So at the end of the session, she mentioned, I feel so much better. I'm so not frustrated, basically, as I was prior to this whole thing happen. So this is where the individualized therapy comes in. And our goal is intuitive eating and helping them understand you should eat basically based on what your body wants and how you feel sometimes, not always an emotional eater, but sometimes those things will happen and it's a normal part of everybody's daily routine, and not beating yourself up about it and making. So we'll see how the progression goes. But I just thought it was very interesting that how the one piece of bread was a make it or break it for her. Although mealtime, she was already having her starches. So just their own perception. We will include goal setting on a weekly basis. So this will be actually more the clients and the dietitian will work on together. It's not my goal for her, it's her goal for her. So everybody's different. For somebody, weight gain may not be a goal, but being able to eat together in front of other people, that becomes a very big thing because a lot of them will be shameful and they'll be hiding. So just kind of individualizing that itself. Self-talk, which is more positive self-talk, which is basically them telling themselves that get your facts and your arguments to base your thoughts versus the eating disorder and help change it. So educating them more with positive self-talk and telling them, okay, take the positive of this, how could you, change this even related to food, and hopefully over time they're learning to incorporate that. Also, I know therapists, along with myself, will be working on just giving them coping mechanisms and distractions when it comes to a certain time if they felt they needed to restrict or binge, and then I wanted to purge. Well, what else could you do? Journaling, I think, and a lot of just emotions kind of come into that. They like homework a lot, and actually it's been shown that if they do homework assignments, they are more engaged in their own therapy, and especially since the homework is kind of followed up and reviewed at the next session. So I think that is a big part of reaching their nutrition goals as well. Food records, we kind of individualize that. Since eating disorders is a lot of obsession about food or calories, some don't want to because they see it, oh my gosh, I usually don't eat anything, or I eat maybe this 2 breads or a leaf or a head of lettuce for lunch one day, and now I'm eating 3 meals, with snacks in between. That's very overwhelming. So for that person, food records would not be it. So I actually ask him, do you feel comfortable? Yes, no, we go from there. And for some, seeing it is awareness, it's accountability, it's being able to see your patterns. I think it's not about punishment. The biggest thing is for the client to be able to see, okay, this is what I'm doing. So for example, somebody says, I eat lunch and I feel like purging after every lunch. So if they were actually writing down what they were doing, and we look at a pattern of, oh, you're drinking like 2 cups of water every lunch. So you're full with the liquid, and you're thinking you have the feeling of being overfull from food. So it may not be that. So well, let's try drinking water either an hour before a meal or right after, and then see how you'll feel. So just kind of again seeing if it works for some of them. Nutrition education entails a lot of different topics. We start off with the basics, which would be carbohydrates, fats, proteins. These are your macronutrients. They are the basis of every meal. This is what a normal meal constitutes. And learning that this is what my meal should have, and fruits and veggies are like my little, what's the word I'm looking for? Just side dishes. It's not my main meal. So just educating them on that, because there's so much of fear around carbohydrates and proteins and fat. So that leaves the fruits and veggies for these guys. Meal planning. This is known to be the most effective behavioral intervention, just because the more structure they have initially, the less obsessive they are, and they actually think less about their meals. And then you take it from there in terms of individualizing it, and actually even having some people just go with intuitive eating if needed. Meal planning gives them less anxiety and less stress, basically, and a lot of their food issues are related to that. It also helps them just get their body in tune with their hunger and fullness cues, because they've been doing so engaged in their eating disorder that over time they just don't recognize what is hungry and what is full. So being on a meal plan where you're eating 3 meals, anywhere from 1 to 3 snacks typically is what a normal person does. Their body, their blood sugar, their metabolism is going back on a regular pattern of eating every 3 to 4 hours. So I think that helps them a lot. One of our goals with meal planning long term is that they develop a consistent ability to be able to pick well-balanced meals, which include variety, and they include fun foods and fear foods, which a lot of these people will have, but eventually we want them to step by step incorporate some of these other things in there. The whole goal is to shift their focus from calorie counting to meal planning. You plan ahead. For example, you head it out, you take a snack with you, you don't put yourself in that position that I'm going to be starving by dinner time, then I'm going to binge, overeat, whatever. Now I need to purge. So if we can hopefully prevent that and teach them that planning and be in that kind of a mode versus doing any of the extremes. And like I said, overcoming some of their fear foods, that was what we would talk about. They have a lot of myths, diet myths, carbohydrates, fats. I had somebody tell me, I don't even like the word fat when we talk about healthy fats. So everybody's in a different place. Some will only have avocado and hummus as their choice. So you just have to kind of teach them that the other foods, and that one food does not make it or break it, or one serving doesn't make it or break it. And also what the role these foods play. So this is where the education part. Why do you want carbohydrates? Main form of energy. Fats, you need it for even feeling actually more satiated, which is something that they haven't been focusing on. We'll be talking about intuitive eating and mindful eating, and just kind of what Janet mentioned before too, where we're trying to focus that we have a structure initially, but it's not like you have to eat the 1,800 calories, or if you need 15 or you need 25, you have to, because we want them to be successful with this on their own as well. Intuitive eating is where basically you're listening to your body for hunger, fullness, by what I feel like today, and not by a rule or a structure. It makes it tricky sometimes because we have to give them structure initially. So at what point do you kind of bring the other one? So just making them understand that they have to trust their body and the weight will settle into a healthful range when normal eating is resumed. So intuitive eating also comes along with no food rules. this is a good food, this is a bad food, I can or cannot have that. You're not policing yourself. You do accept your body, your genetics. If I was a child and I was always middle framed or large framed growing up, aiming to be thin framed or smaller framed is just not a realistic goal to have. So just accepting yourself, part of that is that. And the biggest part I would say is the hunger and fullness. So we had a client who came, week 1 we did a little bit of structure. I realized pretty fast that she was ready for intuitive eating. And we did very well in our outings. We do experiential outings, restaurant outings. Her choices are very good. So within about, I think, 5 days, we moved to intuitive eating. I think the biggest thing with her was she's someone who initiated treatment for herself. She was very motivated, and she really wanted to kind of be there and take control over this. So we went towards intuitive eating, and I think by the time she left, she did pretty well with recovery. Of course, there were other issues still, but I think overall she was in a better place when she left, and I think that's what she mentioned. She liked the fact that she wasn't forced to eat something, and she liked the intuitive approach because that was more her, and she learned to listen more to her body by the end of it. And she was with us for 4 or 5 weeks. On the other hand, I had a client who had social anxiety. And she was anorexic, binge purge type, so either restrict, very big portions, and typically purge after. So with her, I think, we weren't able to work on portions because she didn't believe she had big portions, even though we all kind of very delicately try to tell her that, it doesn't look like a normal sized meal, it's bigger, how are you feeling, things like that. I feel fine. And ironically, she used to say her boyfriend used to make fun of her because he thought she used to eat such big portions. But she wasn't able to accept that. But when she came into the first day, she sat on the corner of the dining table and she was hovering over her meal and she was kind of eating like this. And there's shame, there's guilt, doesn't want other people to judge her plate. So we observed that, and as treatment went on, in her case, she did not want to be there. So I think her motivation was very different. But we were trying, as the team was trying to figure out, are we doing anything? Are we benefiting, her in any way? And I honestly, because I had done restaurant outings with her too, I did a pyology at Spectrum, and literally her face was like this, and then angry, and then get me out of here, why'd you bring me to this group? So a lot of social anxiety with eating. But as the weeks went on, and we do a restaurant outing every week, I have to say she would sit where she was calm. It wasn't her favorite place to be, but she didn't have that fear on her face. And then by the end of her recovery, her journey with us, she wasn't doing the hiding her meals. So she was sitting with us at the table and just eating a meal like a normal person would eating without feeling shy or ashamed about it. In her case, that was how much she gained, but I think that was a big gain for her. She still needed to, go home and work on some of the other issues that were going on, even with, she was active and still active in her eating disorder, but I'm just giving examples of, where they come from and what they bring. Every day is something new and very different with these guys. Moving on with education again, adverse effects of dieting and chaotic eating. This is something I like to go over too, because a lot of them have the diet myths, and just explaining to them that, when you're doing the restriction, typically a diet or a restriction makes you obsess about the food more. So you eventually will give up and do a binge. The binge will lead to a lot of guilt. The guilt will lead you to restrict again. So the cycle goes on and on. Janet mentioned the medical complications. We go over that too, just so that they understand. For example, constipation is a big part of it because you haven't been eating. Now you're trying to refeed and your body will go through changes. There'll be weight fluctuations, there'll be refeeding going on, there'll be fluid retention. So just making them more aware of why it's happening, what's happening. And I want to share the body dysmorphia thing. Again, how you think you're bigger. And we were in session today again, and somebody said, well, I feel fat, I know I've gained, and she did okay. She felt like her legs were this big, and Jade kind of measured her leg with a piece of string or something, and we kind of showed her the difference in what she thought was big versus what the actual size of her thigh was. And there was a distortion there, you know? So I think it made her feel a little bit better, that, okay, yeah, and she admits I have body dysmorphia, but that just kind of made her feel like, yeah, this is okay, not as bad as I thought, just because I've been eating. And she has been eating, she's been restricting for quite a long time. I think body image is one of the trickiest and the biggest challenges with eating disorders, and just trying to change that. I think one of the other main goals that we all try to, not just nutrition, but therapy too, is having them understand and accept the fact that change is going to be slow and that relapses are normal and expected. So even in therapy, we've had people who binge and purged. We knew what would happen, and there's something that they will learn from, and we have to help them learn, but this is not going to be, okay, today I'm done and everything looks really good. Perfect, I'm healed. It's got to be a road. And so I think I've pretty much summed up what I wanted to sum up. Just share some ideas with you guys. And I mean, I think it's challenging, but we have a great team, and I think I feel very proud that all our hearts are in this program, and you know, we just hope to continue to grow from it. And hopefully in the end I can answer some questions too if you guys have any questions.
Hi, my name is Melissa Musi, and I was a client at Sovereign Health for eating disorder, depression, and drugs and alcohol. And as everyone knows, there's so much cross-addiction between all of them, and I think eating disorder, out of most of them, gets overlooked because you can tell when someone's depressed and you can tell when someone's, you know, strung out or something. But since you do have to eat, it's harder to tell when they have the irregular eating habits, or at least just from my point of view. I can remember having my eating disorder very clearly when I was 8 years old, running to the bathroom after eating a huge meal and wanting to throw up and going and doing that and feeling like it was just so normal. And everyone else was a crazy one for not thinking that same way. You know, if I could eat everything I wanted to without gaining a pound, which in my mind that's how it would work, why didn't everyone do that? My family, all of them are morbidly obese. I have 2 older brothers, mom and a dad, and they're both, or actually all 4, morbidly obese. And unfortunately, I picked up their bad eating habits, not their good ones. So when they were going to the gym for months at a time, I would be just doing the protein shakes or just taking their bad eating habits, because of course they didn't have any like purging or binging along those lines, but they definitely saw food differently, and I was just raised with a different relationship with food, and I knew that growing up. Big Italian family, big meals, and yeah, exactly. No, it's true, like the stereotypes are true, and I got that pressure to, why aren't you clearing your plate? But then at the same time, well, why are you gaining weight? You know, that kind of, that gets very confusing for someone, especially, I mean, 8 years old to have a start of an eating disorder. Even coming to Sovereign Health, I didn't admit that I had an eating disorder. Over the phone, I remember them asking me like if they had any scars on my knuckles or anything like that from not only the acid, but biting down because you were shoving your fingers down your throat so hard. And I remember thinking, how do they know that? No one knows that. Like, and even when my hair would fall out, gosh, there was no excuse for that. Everything else I could kind of come up with an excuse why I lost the weight, why I was so pale, why I was wearing huge clothes, things like that. There was no excuse for that one. And it just looked like I was about to die. And I was. And it looked like I was about to die, and on the inside it was so much worse. I have almost 4 years recovery from drugs and alcohol. Thank you. And eating disorder is much worse because I have to eat every day. And I don't have to do heroin every day, but I mean, and it's everywhere. And alcohol is just about as everywhere, but you don't come into a crowded room with everyone eating and feel like everyone is judging the way you're consuming your food, whether you're moving it around too much, whether you're not moving it around at all. The bite size, are you eating everything from left to right? That type of distorted mindset, even though I haven't binged or purged or taken a diet pill or anything like that, I still have that mindset of thinking, because yeah, it's been about 4 years, but only 4 years. And my eating disorder was from 8 to 19. And it took, gosh, 30 days of intensive treatment for me to realize that I had an eating disorder, and then another 30 days to start the treatment for it. I mean, and like you guys were saying, there are those relapses and they're gonna happen. And in my mind, my relapses were every time I ate when I was fully in my eating disorder. But now with the recovery, the relapses, they're not there, because I do see a therapist still. And when I do eat a little bit more, I'm not down on myself about it. Yeah, I may have eaten a bigger portion than a normal person, but it's just that one meal and there's 2 others in the rest of the day, or however many I want, you know? I don't know how much I weigh today. I am fine putting on something in my closet and not have to worry about how it looks. And, you know, I still do, I'm not sure if anyone here has suffered from an eating disorder, but the whole measuring your wrist thing, you know, I still have little stuff like that I need to work on, but I'm not binging, I'm not purging, I'm a healthy weight, I'm not pale, I'm not obsessed about my backbones showing, different things like that, that you just don't really think that anyone in their right mind would think about it. And you're right, it makes you go crazy. This disease is horrible, and I think, like Janet said, it's very underdiagnosed. But with treatment, it's treatable. It gets so much better. And I wish I could convey that to all the 30 million people that suffer from this and more, that it does get better, and you just have to make that first step, because it really does. Thank you.